Hello, I'm Dr. Brian Cole from Rush University Medical Center in Chicago, and I'm going to discuss the biologic augmentation for rotator cuff tear repair. Relevant to this discussion is that rotator cuff disease is truly attritional in nature. It is still the most common cause of shoulder pain in individuals over 60, and it's estimated there's probably more than 6.5 million tears in patients over the age of 65. However, in 2021, we only performed about 500,000 rotator cuff repairs, which means that many people are well adapted and functioning with minimal pain and good function. But this has a tremendous impact on our healthcare system financially. Fortunately, the clinical outcomes are favorable, but we not uncommonly see failure of structural integrity. We and others have looked at what patient preferences are, and generally speaking, patients would like to have less pain and more function. In fact, they would like to have function so much so that they would even take a little bit of pain if it meant that that function could be achieved. And then we're often asking ourselves, does it really matter if the repair is intact at anatomic assessment? And if you look at the literature that actually focuses on functional outcomes, patients with healed rotator cuffs have much greater strength and satisfaction versus those with an unhealed rotator cuff at structural follow-up assessment. There are a number of biologic challenges. We've covered these previously, and you can see them here, but chronicity is really the most important one. And we ask ourselves, why do we re-tear? Why do we fail to heal? It has a lot to do with deteriorating biology. Ultimately, what we'd like to achieve is this enthesis regeneration with a fibrocartilage and mineral cartilage transition zone. But what we often get is reactive scar and failure of the mineralized fibrocartilage matrix. So what can we do to improve biology? Well, we can use extracellular matrix scaffolds to improve material properties, and we can use biologics to improve structural properties. Now, the role of extracellular matrix augmentation has been studied, and there's evidence to show that it increases construct mechanics. It'll improve the intrinsic properties of the healing bone tendon unit. It improves long-term incorporation and strength, and clinical assessments suggest lower re-tear rates and improved outcomes. In this in vivo study, looking at in a canine study by Jimmy Cook and his co-authors, they demonstrated that the human dermis was best by MRI with histopathologic examination, and the animals showed improved range of motion and reduced pain compared to their counterparts treated with amniotic matrix and bovine collagen patch. This is a systematic review performed by Grant Garrigus. It included 35 articles in this review with 5 articles in the meta-analysis. And essentially, when they compared 165 repairs alone to those of 173 repairs with graft augmentation, they showed with graft augmentation that the ASCS scores were greater, and the healing rates were superior compared to allograft compared to xenograft and repair alone. We recently published an article looking at rotator cuff repair and the cost effectiveness. And we showed essentially that you can increase the quality of life years by using graft augmentation, improve function, and decrease revision rates. The surgical technique with newer technology is actually quite easy. Here we're reviewing posteriorly for a right shoulder. The rotator cuff underwent traditional rotator cuff repair technique. The graft is introduced from the lateral portal. It's a 1 millimeter thick graft. A suture tacking device is used to introduce a closed staple, a suture staple, if you will. The gun is loaded with approximately 10 staples, so it doesn't have to be removed and reloaded. We'll typically place 3 staples at the muscle tendon junction or into the muscle itself. We may use one posteriorly, one anteriorly, and then we use suture anchors posterolaterally and anterolateral to dock the graft to the tuberosity as well as to the lateral tendon edge. And essentially, we're trying to drape the extracellular matrix over the top of the rotator cuff to reinforce the repair and to hopefully lead to a more normal anatomic enthesis. Here you can see the posterolateral anchor going in to tether the graft over the top of the rotator cuff repair. Surgical times with this newer technique range between 10 and 15 minutes after the rotator cuff repair. It's a very simple, straightforward technique that no longer involves sort of telescoping the graft into the shoulder as we used to use with earlier techniques. This is that same case where you see pre-op imaging in the top middle, and you see post-op imaging in the bottom, and you can see graft incorporation. And what about biologic options? The most common biologic options that have been studied have been PRP and bone marrow concentrate. We looked at the basic science of PRP with diseased rotator cuff tissue and showed that leukocyte-poor PRP actually promoted collagen synthesis and decreased catabolic cytokines compared to leukocyte-rich PRP. We know that PRP will also recruit MSCs into the area. And when you look at the literature summarizing PRP and rotator cuff repair, there are a number of randomized controlled trials. It often leads to a reduction in re-tear rates, especially for small to medium-sized tears. And leukocyte-poor PRP appears to be the optimal formulation when compared to leukocyte-rich in terms of comparing outcomes with PROs and anatomic structural integrity. So what about medicinal signaling cells? They can recruit other stem cells, they secrete bioactive factors, and they can modulate the environment by reducing inflammation. They can be immunomodulatory and reduce T cell surveillance. Now, there have been several studies that have looked at bone marrow concentrate and adipose tissue as a source of these cells that have growth factors. Hernegas is the most often quoted when looking at bone marrow concentrate and 10-year follow-up showing those who had bone marrow concentrate as an adjunct to surgical repair had an 87% healing rate compared to a 44% healing rate when bone marrow concentrate was eliminated from the surgical repair. In addition, there have been matched case control studies looking at adipose-derived mesenchymal cells, showing that re-tear rates were also lower at anatomic follow-up. Our study, which is soon to be published, is a randomized controlled study that looked at standard rotator cuff repair technique of an isolated supraspinatus tendon. Then at the end of the case, bone marrow concentrate was injected underneath the rotator cuff repair site. In our first 91 patients that were assessed, we showed about a 25% improvement in the SAGAIA scores when looking at MRI at 1-year follow-up. The patient-reported outcomes remain similar. Now, there are other options to consider. It has been discussed by Gus Mazaka's lab and others that actually harvesting the bursa, in this case showing it collecting into a vesicle that's attached in line with the suction, and then re-injecting the bursa after the end of the case as a source of mesenchymal stem cells might improve the local biology. There are also a number of techniques that have been looked at to augment the enthesis, including the use of demineralized bone matrix. This has been looked at in animal studies as well as human studies, and might actually help augment and recreate the enthesis. So rotator cuff tears are associated with poor biology and are largely attritional in nature, which is why we fail. When they do heal, they often heal with scar and continuity and have poor material properties, even if we can improve the structural properties with excellent biomechanical fixation strength. The use of an extracellular matrix in appropriate cases is supported by the basic science and clinical outcomes, and actually could be considered cost-effective based upon our recent publication and analysis. And there is evidence that is accumulating in favor of the adjunct use of PRP and bone marrow concentrate. Thank you very much.